Welcome to the Dean's Roundtable podcast series with Bridget Johnson. Each month, we bring you game-changing conversations about K-12 education and leadership. Join us as top educators, field experts, and administrators share actionable strategies to transform your school community. Let's dive in.
Welcome to the Dean's Roundtable podcast. I'm Bridget Johnson, the founder of the Dean's Roundtable, a space created for student life professionals to connect, learn, share, and grow together. Today's episode, we'll take a deep dive into the critical intersection of medicine and education with our guest, Dr. John Lucas. Dr. Lucas brings a unique dual perspective to youth health challenges. He's both a licensed family physician and an experienced educator with over 15 years in the classroom. After earning his BA in history from Hamilton College, he graduated from the Georgetown University Medical School and completed his family medicine residency at Fairfax Family Practice in Virginia. What makes Dr. Lucas particularly valuable to our conversation today is his extensive work with students who have language-based learning differences, using evidence-based teaching techniques that benefit all learners. He has served as Dean of Students at the Silver Spring campus of the Siena School and currently contracts with schools nationwide to provide health education to parents, teachers, and students on topics ranging from substance use to sexual health and mental wellness. A Maryland resident for nearly 30 years, Dr. Lucas has raised 4 children with his wife, giving him both professional experience and personal insight into the challenges facing today's young people. Los Angeles born but East Coast settled, he's witnessed firsthand how regional differences can impact access to health resources, a perspective that is increasingly important as students navigate different state laws around reproductive health, to name one. Today, we'll explore the pressing health challenges facing young people, from the fentanyl crisis to emerging nicotine products, and discuss practical strategies for parents, educators, and students themselves. Welcome, Dr. Lucas. It's so wonderful to have you here today. How are you?
Thank you, Bridget. I am doing really well, and I really appreciate the opportunity to be here. This is a great honor. So thank you for having me, and I look forward to this conversation. I hope it's useful to all of your listeners.
Absolutely. I know it will be. And so I really appreciate you being here as well. And I'm so glad we had the opportunity to reconnect. So you wear 2 professional hats, licensed family physician and educator. Can you walk us through how these 2 paths converge for you?
Yeah. So education is the nexus. One of the main goals of family medicine and primary care is to help people avoid disease. In the first case, it's called primary prevention. And this concept works best when it's started early in life. And, so the K through 12 education environment is a perfect place to start those conversations early that help guide students to being healthy throughout their lives.
Sure. So tell us about your journey from medical school through family practice residency to eventually teaching at the Siena School. What drew you to working with kids who have language-based learning differences?
It's a question I get a lot. People are like, "You're a doctor. Why did you go into education?" But even before I went to medical school, I was a teacher once I graduated college, and I'd considered going into medicine throughout college, and I did all of the pre-medical requirements like organic chemistry and biology, but I didn't make the call to pursue medicine until I'd been out of college for about 3 years. I originally started at the Royal College of Surgeons in Dublin, Ireland, and
Oh, wow.
then subsequently, yeah, Ireland's a great place. Fantastic education, particularly in basic clinical skills.
Hmm.
But I subsequently transferred to Georgetown and graduated from Georgetown University.
Go
And then
Hoyas. Sorry, I had to interrupt. That is my alma mater. I had to interject just a little.
Absolutely. Um, and, so once I finished residency, I focused on medicine, but over time, I fell back into education and initially was doing things like fill-in family practice and fill-in urgent care, and doing part-time teaching. And then kind of over time fell into teaching full-time, working with the Siena School and utilizing my medical training to help with my teaching. So it's a somewhat convoluted course, but it's been entertaining.
Oh, I bet for sure. So, as the Dean of Students at the Silver Spring campus, what unique perspective do you bring from your medical background to educational leadership?
So two come to mind initially. The first is related to discipline,
Mm,
which I tend to look at through a psychological lens. Um, Basically, I think that the vast majority of disciplinary issues uh, come from a student's, state of mind, either short term or long term. Um, you know, they may have a bad day the day before and come to school upset and angry, or there may be stuff going on over time at home or in their lives that just suddenly bubbles up, and that creates a disciplinary issue. So part of what I do is try and figure out like what is going on in the mind of this student, and where can that understanding help to both apply appropriate consequences, but more importantly, to figure out a restorative plan for helping this student move ahead constructively. Um, and then the second thing that pops to mind is how society perceives you as a professional, um, both because of privilege and societal bias. So I have an MD behind my name. I'm 6'2". I'm obviously white. I identify as male and heterosexual. So I have this long list of kind of privileges in my life. And I think that impacts how parents, particularly, perceive me, especially in a place like the DMV, where you have a lot of kind of high intensity professionals.
sure.
Unfortunately, um, it highlights biases about who holds expertise.
Mm,
And, unfortunately, a lot of people don't value educators as being high level experts in their field. Um, I've been so lucky because the people with whom I've worked in education are, devoted, and they're well educated, and they're creative, um, and they've trained hard, and they work hard to be the best at what they do. And their recommendations and guidance should be viewed with the same respect as somebody would view, say, a lawyer or a business person or a pilot. And it shouldn't be affected by their gender, their race, um, et cetera.
it shouldn't, but unfortunately, we know that that's not quite the case. But I'm curious to know, like in your role as Dean of Students, did you have parents who um, would push back despite the fact that you had an MD behind your name? Like, did you experience a good amount of pushback, even though um, you had the credentials and all the things that you just talked about?
Yeah, I think that there's always, uh, or I think that anybody in education should expect some pushback. Some of that is because some parents feel particularly privileged
Sure.
because of their financial or their, where their job status lies. But a lot of times when educators are dealing with parents, we're dealing with parents when they're under a lot of stress. And
Absolutely.
that sometimes just their stress comes out as, you know, wanting conflict because they need to take that stress out on somebody. So a lot of times, um, it's helpful for me, at least, to try and also figure out where the parents are coming from and work to uh, de-escalate so that we can eventually get around to working together and collaborating.
Well, that's the most important piece, but I also know, especially, what I like to say, parents coming in hot when it's something an issue dealing with their child. We're not the most rational people, and so kind of at that point, all bets are off. You just, tell me what I want to hear, give me what I want, and if not, sometimes people can be pretty difficult to deal with. And so, thinking about de-escalating, I think, in the beginning is super important for deans and any folks dealing with someone who is unhappy.
Yeah,
That's the first step, in my opinion.
yeah. No, I very much agree, and it's challenging.
It is.
Because it gets your own ire up, and
Sure.
it's hard to sort of take that quiet, deep cleansing breath when you've got parents in front of you who are really upset. um, so it takes a lot of effort just to be like, okay, I'm going to focus. I'm the one in the room that has to kind of keep things calm.
Yeah, and not match that energy. You can't match the energy that the parents come in with because no one's winning in that situation at all. So let's switch gears just a little bit. And so you contract with schools to provide health education to parents, teachers, and students. What's your philosophy when it comes to discussing sensitive topics like drugs, sex, and mental health with different audiences?
Yeah. Oh, um, I mean, in short, I talk about sensitive topics at an audience appropriate level.
Mm,
Try and take into account as much information as I can about a particular group's needs, um, what their experience is, what their age is. But frankly, the whole term sensitive topic kind of frustrates me, annoys me, um, and that's a discussion all in and of itself,
hmm
um, because I look at the topics that I cover, and I strongly feel like they shouldn't be sensitive.
Right.
Unfortunately, many cultures find discussions related to human reproduction, the human body, mental health, etc., as uncomfortable, bordering sometimes on taboo.
hmm
Um, and then that sensitivity is passed from generation to generation to generation.
Yeah, absolutely.
So, one of the goals I have for myself is, trying to provide data driven information to the groups with whom I speak to help them make informed decisions, but also to normalize these conversations so they aren't inhibited by, uh, sensitivity.
I think that's awesome. But so, can you give us an example of how you tailor your message when speaking to parents versus teachers versus students about the same health topics?
Mhm. Yeah, I mean, generally speaking, my overall message I think is the same,
hmm
uh, and that is taking care of your health is essential throughout life. And one of the ways to help take care of your health is to be informed, to have access to quality data, skilled people that can give you resources. And that way you can make informed decisions. Each of those three groups has different challenges, as far as imparting effective health messaging. Students, they oftentimes need age appropriate and socially appropriate messaging. Teachers, they're in this unique position, and unique may be too kind a word. They're in this challenging position where they're having to impart information that some people can look at, as being inappropriate, and they have to pass that information to students that aren't their own kids. They aren't the parents and the guardians, and so that can be a difficult field to navigate. And then, parents, of course, want the best information that they can get about how to deal with their kids. And, parenting is hard. And so
It
ideally,
is.
you want somebody who can pass that information along with sensitivity.
Yeah, and sometimes I think when you talk about sensitivity, um, do you feel like sometimes we're a little bit too sensitive to parents, and not just kind of telling them like it is, or telling them really, being very direct in kind of what's happening and how they need to deal with it, instead of kind of, uh, kind of dancing around the issue, for lack of a better term?
The I sort of interpret that as the topic of, I don't want anybody to feel uncomfortable.
Exactly.
and, and the nature of life is that you're going to be in situations that make you uncomfortable. Yes, I want to be sensitive to people's trauma and be aware of it, um, and be cognizant of the possibility of triggering people. Um, but that doesn't mean that we have to be so obtuse and vague that the message doesn't get across. And frankly, I think a lot of times a direct approach is the easiest and the most understandable. Um,
Hmm.
Something that I've used both in clinical practice as well as in the educational setting is I tell people what I'm going to tell them before I tell them it. So, I say, hey, I'm going to, in the clinical setting, I say things like, hey, I'm going to ask you about, who you've been with and, what resources you use to keep yourself healthy.
Hmm.
Um, and then I ask them directly. So it allows them a couple of seconds, a minute or two to sort of prepare. They know what's coming because
Right.
I've already asked it, but they have that moment to sort of settle down and be like, okay, um, I can think this through and formulate an answer. And also by telling them what I'm going to ask them ahead of time, it gives me the chance to set my body, my body language, my facial expression, my tone of voice to say to people, hey, yeah, this is a challenging topic, but I'm here to be supportive and understanding and give you what you need to help you.
We don't talk about body language and facial expressions enough. I know personally that was something I really had to work on, in my early days as dean, because I was not good at masking when I was annoyed, confused, all of the emotions above. And it's not necessarily masking, just, kind of relaxing it and listening to understand instead of respond.
Yeah.
And so I appreciate you mentioning that, because as folks who are, working with students and parents and other, adults, your colleagues, people can read oftentimes, your body language and your facial expressions, despite what's coming out your mouth. And so, or not coming out your mouth. And so, that can really hinder a conversation when you're trying to, one, um, get some important information, or, be vulnerable, or be very detailed about kind of what's going on. And so I really appreciate you mentioning that.
Yeah. Have you got a second for me to give a
Oh,
specific?
absolutely. Yeah.
So my office, when I was dean of students, had a sofa in it, and I had
Hmm.
a typical office chair that I could raise up or down a couple of inches. And I had students that were typically anywhere from about sixth grade up to high school. So in a lot of cases, the students coming to me meant that they were looking at a tall man,
Uh,
and therefore, and the sofa was low, so I would get
wow.
off my chair and I'd sit on the floor and try and bring,
Good eye level.
yeah, myself to their eye level. Um, and I think that was one way of helping sort of disarm the intensity of the situation. Um, Now, on the opposite side, I know teachers um, who, might be 5'4", and they take the opportunity to sometimes have meetings where they set themselves up higher, particularly with parents, just to try and establish
Yeah.
um, a little bit more of a power dynamic, which I think is
Hmm.
legitimate. Um, you know, so that those
Yeah,
are
I,
two.
I could totally see both sides of that. No, absolutely. And wanting to make students feel comfortable, but also wanting to make parents feel like you are in charge of what's happening in this space and
Yeah,
you are in control of the situation. So I can absolutely see both sides of it.
yeah, yeah.
When I was giving you giving your introduction, I mentioned briefly, students having to think about navigating different state laws about reproductive health, which I think is just, crazy. It's not something that, we had to think about necessarily as we were coming out of high school.
Yeah.
But and so the importance of preparing 11th and 12th graders for those potential impacts on their access to sexual health care and abortion when they transition to colleges in different states. How do you approach these really politically sensitive conversations? So easy, such an easy question, right?
Well, the thing that gets me is these conversations shouldn't be um, they shouldn't be political. And unfortunately, invented fear and dogma and feel facts have supplanted um, experts and the
Mm.
legitimate use of data. Um, it This is one of these moments where I'm trying to compose my face and my body language because that thing really just it makes me so frustrated. And the other thing is, I find it super ironic that as teachers, we're asked to help train students in civil discourse, to
Yes.
try and use reason and to try and use legitimate data, and use that data to support their contentions. And we're doing this when so many adults in their world struggle to do the same thing to such a degree. I mean, the bombardment of angry, uh, just angry discourse that is, where ideas and thoughts are created out of thin air just irks me. So, so I try to provide the best possible data I can find. Um, Try and find the best facts, or at least find expert consensus from people who actually have experience in the fields that they are professing on. um, and so the people with whom I talk can make the most informed decisions that then they can incorporate into their particular value systems. I'm not here to change people's values. Um, that's not my job. I just want them to have good information.
Sure.
Um, so as far as students, traveling to different places, my main message is that they do their best to learn about their reproductive choices depending upon where they expect to be going.
Hmm.
And unfortunately, I have to put it on them because, particularly now, law has been changing so rapidly. I can't keep up.
Right. That's
Um,
fair.
so, and an additional challenge is that a number of resources that I used to consider legitimate and valuable I'm concerned about.
That's fair. Yeah.
So at least in terms of places where I think there's still valuable information to be acquired, the World Health Organization I think is a good resource. There
Okay.
are a lot of medical schools that maintain good resources in regards
Okay.
to health education, and the Canadian Health Department,
Oh,
um,
wow.
based on my estimates, also maintains good resources.
Who knew? The Canadian Health Department. Okay. I'm gonna make note of that for sure. Um, all right, so let's move on and talk a little bit about substance use, and kind of what you're seeing out there now, and what are the hot drug, like what is most popular right now with students, would you say?
Well, I think that alcohol and marijuana are probably the ones that are most like, popular because they're readily available, and I think many people consider them not that bad, and we can get into, I'm sure we'll get into some of those details in a bit. Uh,
Right.
I don't think we are seeing as much of cocaine and heroin and crack and ecstasy and the like. And the data that I have been reading most recently suggests an overall decline in use of illicit drugs.
Okay.
And in fact, I was reading this morning before I got on this podcast with you an article from NPR that has talked about significant declines in fentanyl deaths. Um,
Wow.
so,
Okay.
yeah.
Well, that's interesting because I do feel like, in the last couple of months, I have had the question posed to me from some deans around the country about Narcan availability
Mhm.
and whether or not they should have that on their campuses. And back when, not even that old, back when I was a dean, that wasn't even something that we had considered in
Yeah.
terms of needing to have some counteraction to the drugs that students may kind of find themselves using. And so, as we talk about fentanyl and talk about, I hope that there's a decline in the use of that substance on school campuses, but is the Narcan availability rising for school campuses, and what have you seen in that area?
So I don't know data about whether schools are bringing it on campus.
Okay.
My recommendation from a health standpoint is absolutely it should be available on campuses. Parents should have it. I think that especially like high school students, because particularly they're uh, utilizing their independence a lot more. So they're going out on their
Sure.
own with their friends and to parties and stuff like that. I would highly recommend that they get Narcan. And a number of states uh, provide Narcan free of charge, and a number of health insurance organizations will allow you to get Narcan for free without a prescription.
Okay.
So it's available, and it's available with little or no cost and little or no hassle. So yeah, I would like anybody should have it available because it's super easy to use. The little
Okay.
nasal actuators um, are super simple. You just put the tip into somebody's nose. Um, you don't have to probe for the eyeballs, but
Okay.
half an inch or something like that, and then there's just usually a little red actuator button that you push with your thumb,
Okay.
and sprays right into the nose.
Okay.
And if somebody's down because of narcotics, Narcan can be life saving. And if somebody's down because of some other substance, giving them Narcan isn't going to make the situation worse. It isn't going to hurt them. So,
Okay.
you can use Narcan without knowing why somebody
What's what
is
substance
down.
they've
Yeah.
used? Got it. Okay. That's actually good to know. I didn't realize that. And so, you talked earlier about marijuana and alcohol, and how those are still the kind of the most prevalent, uh, I guess, substance of choice, for lack of a better term.
Mhm.
Let's talk about marijuana a little bit because it presents some complex challenges beyond what many people realize. Can you break down the risks that you're seeing, particularly around acute psychotic reactions and impacts on learning?
Yeah. So I've started in my slide presentations putting an image of a guinea pig on some of my slides. Um,
Okay.
and the idea behind that is to say, you know, on this particular topic, there is little data available. And so for somebody that engages in the use of whatever substance it is, and marijuana is one of them, the people that use are essentially the research guinea pigs.
Mm,
You know, you are using something where we don't have clear ideas about short-term and long-term impacts. We have some, and you know, with marijuana, we're seeing a lot more evidence coming out. Um, but you know, the things that I've seen the research show in regards to marijuana. One, it has significant impacts on cognition. Um, it can severely limit long-term learning,
okay.
and you know, so when we look at students, particularly who are like, you know, I want to go to college, I want to make something in my life. Marijuana can have a significantly detrimental impact on that. And it is specifically, or it seems to be specifically related to how rapidly their brains are growing and how much change is going on in the hardwiring of their brains. Um, so we don't see it as much in people over the age of, you know, 30, because by
Okay.
then most rapid brain development is done. Um, Marijuana increases the risks for depression, suicide, anxiety, psychotic episodes, as well as long term psychosis.
Mm,
Um, Marijuana is addictive. And, you know, studies are showing that somewhere between about 22 and 30% of users are addicted to marijuana, meaning they can't get through a day without having marijuana in some form or another. Um, there is a condition called cannabinoid hyperemesis syndrome.
wow. Okay. That's a mouthful.
Yeah, this is why medical school takes so long, because we just have to learn how to say these lengthy, convoluted terms. Cannabinoid hyperemesis syndrome is just it's a barfing, it's a vomiting syndrome related to marijuana use. So people use marijuana and they end up in the ER because they just can't stop throwing up.
Oh, wow.
Cannabinoid refers to the particular chemical in marijuana, and hyperemesis is just the doctor term for vomiting.
Okay.
Um, so, and the treatment for that is you have to stop using marijuana. Um, then evidence is conflicting about what impact driving or, you know, operating dangerous machinery
Sure.
is under the influence of marijuana. Some studies suggest that it impairs reaction times and increases the risk for accidents. But, you know, for example, there was a National Highway Transportation Safety Administration study that contradicted this. And
Hmm,
so the bottom line is I don't know the answer there. And then depending upon how the marijuana is ingested or
okay.
utilized, you know, is it smoked? Is it through edibles? Is it through dabbing? Um, there are risks suggested for cancer, lung disease, and unintentional overdoses in children who get their hands either on edibles
Mm,
or they get the resin that's used in dabbing. So there are a lot of there's more and more evidence showing that marijuana is a problem. Um, and part of that is because the cultivars, the breeds of marijuana nowadays have upwards of I think 200 to 300% more THC
Wow.
in them than the breeds of marijuana that existed 20, 30 years ago.
Oh, that's a lot more. Uh,
Yeah.
and you just don't know how your body is going to react or respond to that, and so that can be very scary, especially
Yeah.
for students who are experimenting for the first time, I would imagine.
Yeah.
Um,
And actually, to take that comment you made about for the first time and relate it back to fentanyl,
mhm.
just quickly, I talked about the NPR article saying fentanyl use or fentanyl deaths are down, but still, fentanyl remains a problem. It is an incredibly powerful drug, and the Drug Enforcement Administration has a program. It's called One Pill Can Kill
Okay.
because, you know,
Literally.
yeah, literally, and it can be a single pill in somebody who's a first-time user. It can be a single pill in somebody who has used before. Because particularly illicit drugs are not, there's no standardization, and
Right.
fentanyl is cheap, and therefore it's frequently used as an adulterant, and you don't know what's in that pill. So anyhow, I just wanted to um, get that in there. One pill can kill, and there is a good resource from the Drug Enforcement Administration about that.
I appreciate you mentioning that. And so, and talking about not knowing what's, kind of in that pill or in the drug that you're taking, I want to kind of mention that with regards to alcohol,
Mhm.
because, when students, drink, they think they're, know what they're drinking. We're not even talking about whether or not someone's slipping something into your drink. But if you're currently on medication and those interactions with medication and alcohol can be really serious and dangerous. And so, how do you reframe conversations about alcohol with students in those situations or in those scenarios, rather?
Yeah. So I don't, I think, reframe. I just tend to try and keep updating my information
Okay.
in regards to alcohol use. Um, the big change that I've been seeing in the data about alcohol is that alcohol has negative impacts that are graded on the quantity of alcohol consumed. There is no healthy alcohol consumption. My apologies, particularly to those of us that grew up, hearing that red wine, for example, might be good for our cardiac health.
Hmm.
Um, so
Uh-oh. So you're telling me that that is not the case?
yeah, yeah, not that, apparently not. Um, but I think generally speaking, adolescents aren't focused as much on long-term consequences. So, I tend to really focus them on the short-term risks, like motor vehicle accidents and physical trauma, um, and not just to the individual person, but to other people. Because it's a tragedy when anybody dies in an alcohol-related motor vehicle accident.
Absolutely.
It's uh, I think a whole other level of tragedy when somebody who is under the influence gets into an accident and the people that they were driving are killed and they survive.
Oh, yeah.
So, really focus on the possibilities of traumatic injury and death. Um, Something called aspiration pneumonia. This is where somebody who was drinking alcohol, they get tipsy, they throw up, and because alcohol impairs the gag reflex, which would normally protect the body from material going down the breathing tube, the trachea,
Hmm.
um, they throw up, and then they inhale some of that into their lungs. and the combination of acid and bacteria sets up a really bad lung infection that's hard to treat. There's the risk of choking, where a piece of something lodges in the trachea and blocks it. We have lots of data to show that injuries and deaths from firearms are often related to drinking, as well as sexual assault, rape, um, acquisition of sexually transmitted infections, unintended pregnancies, and then the negative impacts on somebody's ability to do their schoolwork. And it just there's a whole host of short-term negatives for alcohol use, and those are the ones I tend to really focus on.
Hmm.
And now more and more, to really get to the basis of your question, we have so many students who are taking antidepressants, anti-anxiety medications, ADHD medications, appropriately prescribed for the right reasons. Um,
Sure.
but when you start adding alcohol to that, you begin to increase the likelihood of bad interactions that lead to injury or death. And in medical parlance, it's called polypharmacy. So the
Uh,
more chemicals you throw into somebody's body, the more likely those chemicals are going to combine to cause some negative impact on the human body.
oh, so much to think about. And I'm like, oh my gosh, I'm not sure what I need to do right now, but one of the things that I think is important is just to continue to talk about this, and get this information out there for parents, students, and teachers and administrators so that they have information. Because knowledge is power, right?
Yeah. And,
Um,
and knowledge is also that knowledge can be really helpful to students because a lot of times there's social pressure to
sure,
engage. Hey, have a drink.
absolutely.
Um, and so I say to students, hey, look, uh, you know, if you take a medication, there's a great excuse to say, hey, I'm taking a medication and I can't use alcohol with it. The doctor has told me, you know, I can't mix it with anything.
And mixed, right?
And, you know, ethicists may get on me for saying this, but I have no problem if, a student lies and says, I'm on a medication, even if they're not, just to provide an excuse to avoid, using alcohol or drugs. I think that's a legitimate excuse. So,
Oh, that's fair. We do need to give students some language or some words to use when they're faced with these situations. Just telling them not to do it and resist peer pressure is not enough. And
yeah,
so, being able to provide some scenarios or some different ways that students can say, "Yeah, hey, I can't," or "I'm not, I won't," or "I'm not supposed to," is really helpful.
yeah. More and more of my conversations, I'm trying to focus on what can you do to avoid use, because I think most kids are pretty aware that the various substances out there have negative consequences, but what they're less certain about is what can I do to avoid using them in the first place. And so those are the strategies that we really need to be focusing on and giving students and parents.
Absolutely. So I want to come back to that because strategies for delaying or preventing young people from using in general. One of the things I did want to just mention briefly is nicotine because we haven't talked about that. And I just recently became aware of these new pouches that students are using. Where I'm like, oh, I thought we had moved past the dip stage, and now we've got dip 2.0. And I'm like, no. So. What concerns you most about this trend, and how have you been addressing it?
So if I could, again, this would be a guinea pig moment. If I could just float a little guinea pig up here,
Yeah,
um,
absolutely.
because there is not a lot of data out there. Um, the vast majority of our data refers to tobacco, so cigarette smoking as well as dip. and snuff and stuff like that, where it's the whole leaf.
Mm-hmm.
And there's less evidence available about these Zyn pouches and the like that are just nicotine and in and of itself. And an added complexity to this is that in January of this year, the FDA authorized it's called a for-marketing letter for 10 Zyn products. So just those 10 Zyn
Wow.
products. It's not even like the whole pantheon of other nicotine products out there. And for marketing just means that the FDA says as I understand it, if there's anybody from the FDA out there listening, please let me know. But my understanding is for marketing means the FDA doesn't have any evidence to suggest that this material is so bad that they should restrict it. So they're saying, all right, it's okay for companies to put out advertisements and market their product. And they're supposed to market their product for people over the age of 21. But nicotine pouches have their flavors. It's easy to tuck a pouch between your cheek and your gum or under your tongue, so it's easy to use them clandestinely. And they are a good stimulant, increase people's energy, and they elevate people's mood through dopamine impacts. So, talk about something that would be appealing for under 21s, and you've got it.
Yeah.
So the downsides of nicotine are it's highly addictive. 2, 3, 4 uses, and it sets up a chemical addiction. It has a strong dopamine effect again, so it's this feel-good thing. It elevates mood and contributes to focus. So again, there's a lot of appeal in addition to its addictiveness. But again, we just don't know the long-term effects. But theoretically, because it affects blood pressure and it affects heart rate and it affects the activity of your intestines, there are potential harms down the road. And nicotine in and of itself is a toxin. About 20 to 30 milligrams of pure nicotine is toxic to adult humans. And Zyn pouches, I think there are 3 milligram and 6 milligram pouches.
Okay.
So, and they're supposed to release their nicotine over time. But, an additional issue is like 10 milligrams of nicotine can be toxic to little kids. So, a little kid gets into a nicotine pouch that has 6 milligrams and,
Yikes.
yeah. So,
Oh,
we just don't know.
right. So going back to my question about, strategies that are effective for delaying or preventing young people from trying these substances in the first place, what you got for us? Because we need to be proactive in this area. We can't wait till students start to use and then talk about not using.
Yeah,
We're too late.
yeah, yeah. So we're too late. Begs or suggests one main impact or one main strategy is like, get talking to your kids early, like elementary school, and then additionally, update those messages as your kids get older. Update the messages as far as complexity is concerned, as far as how those messages relate to your child's experience. One reason that a lot of people end up engaging in substance use is for self-medication.
Mhm.
So they're anxious, they're depressed. Life just kind of stinks and they want to feel good. So, the logical retort to that is there's a couple of them. One, give kids the opportunity to communicate and learn about what's going on with the kids, and encourage discussions about feelings and mental health so that those feelings can be addressed in an appropriate professional fashion. A lot of kids, and having taught in schools for kids with learning differences that are undiagnosed are a big problem because
Mm,
students start feeling frustrated and anxious,
sure.
and uh, they seek substances that may help them concentrate and improve their academics. So, you know, if you have any concerns that your child may have a learning difference, get them tested. And I know it's expensive, and I know it's sometimes hard to access, but if there's any way to get them tested, um, and get them academic help that's appropriate to their needs, that can help diminish their likelihood of substance use. Um, Provide kids with dopamine experiences, those like healthy experiences that make them go, wow, this is really great. Go
Yeah.
for a walk, get on a roller coaster, go for a hike, go for a run, dance, do yoga. There are so many ways that we can get kids out and engaged. And we can do those in lots of different environments, lots of different socioeconomic settings, but give them regular opportunities to do stuff that makes them feel satisfied.
Mm,
Parents need to be role models. Once you're over 21, you can use alcohol, and in many states now you can use marijuana.
right.
Um, but as parents, we need to be showing our kids how to use those legal substances, use them appropriately. Um, and, there are a lot of other things that we need to be mentoring them on, how to deal with emotional upheaval. You know, we as grown-ups need to seek mental health support
Hmm.
if we are struggling, because kids are highly observant.
They are.
Watch,
Absolutely.
they watch the grown-ups in their lives. And ultimately, what we're seeking to do is to try and delay for as long as possible um, any substance use. Because there was one piece of data I was looking at yesterday that early substance use, sort of under about 16,
Hmm.
increases the risk of substance use disorder fourfold. So
Wow.
we want to try and delay, delay, delay. All right, sorry, that was lengthy. I'm sorry.
No, no, that's fine. I mean, it's important information and definitely what we want to know about. And so, thinking about practical applications and kind of moving forward from there, when you're presenting to parents, what are the most common misconceptions you encounter about youth substance use and health risks?
um, Misconceptions. Um, Talking about substance use will lead to substance use.
Huh,
That's a huge misconception. It's baloney. There's clear evidence nationally and internationally. Talk, Start talking early, start talking regularly, and you significantly decrease the risk of substance use. Um, Sort of related is the misperception that there's an age at which you can start talking about this stuff. The age is start early, speak
right.
regularly, address those conversations, so that they become, consistent, comfortable. Because as kids get older, it may be harder to get them to listen to you.
Right.
So make them normal. Um, we kind of touched on this before. If I try a substance once, it won't be a problem. Well,
Mm,
DEA, one pill can kill. Uh,
right.
and so I try alcohol once, that won't be a problem. Well, what exactly do you mean by try? Because if you knock back a cup of vodka, and you knock it back literally like you shoot it, or over the course of 10-15 minutes, that can make somebody seriously impaired. um, there's a misconception that substance use is a moral issue
Mhm.
and that it should be dissuaded by shaming and guilting people. Um, and, you know, that just pushes the conversation um, underneath and hides it and stops conversation. Um, Another misperception, I think I have two more. Parents are worried that they're going to say the wrong thing. And
Mhm.
I think my experience with students and our own kids is, yeah, as a parent and a human, you're going to make mistakes, but kids are pretty resilient. If you
Sure.
acknowledge your mistakes and you discuss them, um, you will reach resolution and understanding. So don't not talk because you think you might make a mistake. And then the last one is the idea that I live in a community that's a good community, and so I don't need to worry about substance use.
Yeah, I don't think that's quite right. And I'm just gonna leave that one there. Um, um, a couple more questions as we look to close. For
Yeah.
educators listening who want to better support students around these health challenges, what's your top advice?
Um, so, in an ideal world, we would have a system that linked educators, students, parents, and guardians in this nice circle of communication where people trust each other and they discuss and they find support.
Hmm.
I think also it would be really nice if we could almost Venn diagram that circle of educators, parents, guardians, and students with health, healthcare,
Uh,
um, and you know spend some time understanding what goes on outside of the school because there's this realm of what are called social determinants of health, things like economics, how clean the environment is in a community, how much community support there is, access to health care, access to good education. And the social determinants of health have a roughly 80% impact on people's overall health. What I do in the clinic impacts somebody's health roughly 20%. So there's this huge realm. And if we can try and help understand that better and help figure out how schools and communities can better interact to mitigate some of those problems, I think that we could go far towards supporting students. Having said that, teachers have so many mandates to
me
fill.
too.
And so what we really need isn't necessarily more mandates for educators, but we need more support from state and local communities, mental health support, reproductive health education, and you know even not for profits and religious organizations can really step up and help provide this. So uh, I think that covers it um,
Okay.
in the moment. I'm sure that tomorrow I'll be like, there are all these things I missed.
Well, we'll just bring you back on. Not a problem at all. So I think we talked a lot about kind of what's trending out there, but is there anything that I hadn't that we haven't discussed that's out there that you feel like is important to bring to the surface or highlight?
I think that we've covered a ton, and I really appreciate the opportunity to do this. To kind of recap, start the conversations early, keep them going. Um, we really need to focus on not what are the dangers of substance use, but what are the reasons that people get involved, and then how can we, through personal interactions, community support, society, political strategies, can we help to educate our youth to support them in delaying or avoiding substance use in the first place? Um, those I think are the like two main messages from this whole conversation.
Awesome. And I think that's a great place for us to close. But before we do that, for listeners who want to learn more about your work or bring health education programming to their schools, how can they connect with you?
So I have a website. It is www.lucashealthconsulting.com. And if you go to the Contact Me tab, there is a form you can fill out. You can email me directly at MRDRLUCAS, Mr. Dr. Lucas, at lucashealthconsultants.com. And I'm on LinkedIn, so any of those are easy ways to get in touch with me if you have additional questions.
Awesome. And so we'll also provide those links for folks. And so I have to ask this question before we leave because, you have the MD after your name. You were a dean. Did anyone ever call you Dr. Dean, or was that just not something that happened?
No, so the Mr. Doctor thing at our school, at the Siena School, we were formal, so the students referred to the teachers as, Mr., Miss, Mix,
Sure.
whatever. I was for a while the only one who was either a PhD or an MD.
Okay.
And so the students would get confused because they knew that they were supposed to call me Dr. Lucas, but they're used to saying Mr. to people that identify as male. So I'd frequently get this Mr. Doctor. And so it became part of my email.
I love it. Well, I had to ask because I'm like, oh, that would be kind of cool if he was known as Dr. Dean, but Mr. Doctor is pretty cool too.
Yeah,
And so, again, thank you so much for joining us today. It was an enlightening conversation. I learned a ton, and I think our listeners have as well. And you are welcome back to the Roundtable podcast anytime. We'd love to have you.
that's great, Bridget. Thank you so much for this opportunity. I can't tell you how much I appreciate it. And I wish you well. And keep doing the great work that you're doing.
Oh, thank you so much. And so, thank you guys for listening to another episode of the Dean's Roundtable podcast. If you enjoy what you heard today, like, share, and do all the things on social media. We appreciate you. And until next time, we'll see you soon.
Thank you.
Thank you for joining us for this episode of the Dean's Roundtable podcast. Is your student life program delivering on your mission? Our new K-12 student life assessment moves you beyond anecdotes to evidence-based decisions. Through comprehensive stakeholder surveys and expert analysis, you'll get concrete insights across 8 essential dimensions of student life, from culture and wellness to staff effectiveness and resource allocation. We are seeking founding partner schools to be first to experience this transformative assessment process and help shape the future of student life evaluation. And because this work shouldn't be done in isolation, join our Student Life Professionals community of practice, facilitated monthly with Trey Education. Connect with fellow deans and student life leaders for real-time support, idea exchange, and solutions to your biggest challenges. 8 sessions per year plus ongoing collaboration through our shared messaging group. Whether you need data-driven insights, peer connection, or both, we're here to support your student life leadership. Learn more at deansroundtable.org. Today's episode was hosted by Bridget Johnson in conversation with Dr. John Lucas, produced and edited by Andrick Sigmund, and music by PremiumBeat.com. For any questions, contact information can be found in the episode description, and, as always, thanks again for listening.